network.
Awesome.
We ended up with the BHI as a term that fit with what our folks are used to, which is the same as IBH.
Oh, gotcha.
So it's ABIN, ABHIN, as just a quick little. So
that behavioral health webinar, if you want to listen to, you can from the headphones in.
So we have 13 people signing in. Most people are doing audio only. Let's see, it's 7:58. Our other speakers have mostly done presentations and get some feedback. I'll be monitoring the chat, but
no, it's on mute.
It's not.
And Patty, we'll be trying to monitor the chat as well. It's nice. This is also nice when you have two people, because we usually try to have one of us monitoring the chat box. But if there is something that comes across that we're just not even acknowledging or paying attention, please let us know.
Awesome. Is there anything else you're needing? I mean, Kim Schuler, you can see, she's really our executive person that runs ABIN, and I'm kind of on the side. But as a team, we're trying to make this happen. And so I don't know if y'all have even met Kim and Dr. Bauman, Dr. Beachy.
Absolutely. Thank you, Patty. Good morning, Dr. Beachy and Dr. Bauman. I do a little work with CHCW, and I've been on one of your webinars before with CHCW as a participant. So we appreciate you so much coming out and doing this. As Patty said, we're trying to, in some form or fashion, replicate a similar organization to IIBHN. I also wanted to say thank you for doing this. I know it's early on the Pacific Coast, and so as I was getting up this morning, I was thinking about the time differential and thought, wow, you guys are really dedicated. So we appreciate you. That speaks to your passion about this work.
Yes.
You know, the thing that Bridget and we have come accustomed to, we usually get up around the same time that we got up for this, and we usually just start talking in the morning about primary care behavioral health. So this really isn't any different. We're just dressed up, actually.
We may or may not be recording it.
Yeah. So.
Awesome. Well, we appreciate you so much. It is 8 o'clock. So I'm just going to give a brief introduction to the group, and then it's all right, I'll ask you to introduce yourselves. This morning we have Dr. Bridget Beachy and Dr. David Bauman with us. They are health psychologists. They have a long history of integrated behavioral health, and also do these types of trainings not only nationally, but internationally. So we are so grateful to have you here today. And if you could tell the group a little bit more about yourself, I know that was fairly quick.
That was great. Yeah, so, and I will say, before we get into details about ourselves, definitely use the chat box. What we found that in groups, it seems like, you know, there's 10 plus. We are, you know, because there's two of us, one is always able to monitor the chat box, and we want to make this as interactive as possible so you get the most out of it, especially if you took precious time out of your day to be here. So anything that you want to talk about or something that doesn't make sense, you want clarification, we'll be keeping our eye on that chat box. So please, please, please use that.
And Patty, Kim, I'm also going to ask you, if you notice, we go off on tangents regularly. So if you know that we're like, hey, you guys have been through like 2 or 3 slides and we're 45 minutes into this right now, please just send us a message, be like, hey, just aware of time that we have.
Keep it moving.
Yeah.
So just to, you know, provide a little bit more context. So I'm Bridget, and I work in a federally qualified health center, as does Dave. We work in the same organization, and it's kind of neat. We have almost kind of like a co-director type of situation going on where I'm the director of behavioral health, so all clinical staff and clinical behavioral health consultants are going to be reporting to me. And then we also have our working organization that has both a medical residency as well as a pre-doctoral psychology internship and a post-doctoral fellowship, in all things education route up through Dave. And of course, the clinical and educational, the constant overlap. So we are in Yakima, Washington. It's in the middle of the state.
Exactly where it is.
Oh, all right.
There we go.
Yeah,
That's
it's not rainy. It's like a desert. So I know that throws people off sometimes because they think of Seattle. We're 2 hours or 2.5 hours east and south of Seattle. So long story short, we work in a medical clinic. We work as behavioral health consultants, seeing patients all day long, and then we have our administrative and our teaching roles. Is there anything you want to add to that?
No, the only other thing that I would add to that, and I would also add, we always try to give this preface while we're doing presentation. We're married, so if there's like any it's like man, it's like they're really interacting with each other like in a weird. We're married, so that's why the way that we do. But the other thing that we really try to say when we start off these webinars is that we are kind of unapologetically supportive and proponents of the primary care behavioral health model and integrating behavioral health providers within primary care. And then also huge proponents of taking a contextual approach to dealing with the vast things that come through primary care. And I think that's the thing that we're going to really try to talk about today, in addition to just kind of structure and contextualism and trying to provide more compassionate care, is that we really do believe that taking this approach really can have some unbelievable outcomes for our patients, for our organization, our clinics, which we'll also go over a little bit today.
All right. So with that, oh, no, I got it.
Do you have it?
I do. So with that, I know. All right, here, you do it. We're going to probably say things that might be, I don't want to say like controversial. I don't want to freak you out, Patty or Kim. I wouldn't say controversial, but maybe some things that are contrary to what you maybe learned in graduate school, because we know that a lot of the things that we were trained in graduate school with both our master's and our doctorate are different now. So, we're going to challenge some assumptions, and it's not about either of us or anybody being right or wrong. It's just about looking at things from different lenses.
And I'm really glad that you framed it that way, because not only do I think we kind of take a unique approach to just what is health and how we go about intervening with the common things that show up, we also, I think, take an interesting approach in just what integrated care is supposed to be. As everybody probably on this call has probably read articles or books, whether it be about the primary care behavioral health model or just integration in general, we will probably say some things today. It's like, oh, I haven't heard that said before. Oh, I thought this was supposed to be just like brief interventions that are done within primary care behavioral health. And while I would say a lot of the things that we do are brief, it's not superficial by any means, and we'll get into that a little bit more. We always like to say, as Bridget said, we're here with you, and as we're not saying our approach is right or wrong. We're contextual people, and so really the only thing that matters is if what you're doing accomplishes the goal. So we're just saying that this is helping us accomplish a goal. And while integrated care is great, it is something that's really hard to do. So make sure that you're being kind to yourself on this journey. If you're a new clinic that is starting up, that is starting to integrate behavioral health providers, maybe you're a behavioral health provider that's in a new clinic, or you're medical, or you're an administrator that's trying to get this off the ground. It's like, you know what, I go to all these things and people talk about, oh, this is so great, this is so easy. We always like to show this next slide and this next picture. A lot of times integrated care can feel like this, which is, I always like bragging on Bridget. She won an award at the Cloud Family Healthcare Association. So it was a good day, it was a good day, we're smiling. And then it can also feel like this, where you're absolutely in the corner with tears and crying and just really having a difficult day. And this is a picture of me not being a good supportive husband. That is literally, what was it, probably like 6 or 6:30 in the morning. We're at the office.
And I don't even know what happened. I'm sure there was some thing that came through the email, and I was not in good state of mind, and obviously I was like that. So Dave comes up and takes a picture of it.
Yeah, I was not being a good supportive husband. I tell you what, it's worked out great for presentations now, though. And I think this is where to have kindness and grace for yourself throughout this journey. I think a lot of times with grants, with these new initiatives, that almost makes it seem like it's going to be easy to do, to get to this fully integrated place where everybody's working in like this harmony, this really great thing that everybody gets along and the workflows are shared, everybody's bought in. I don't know of a place that actually has that. And I think it's a really difficult thing when presentations get done, because I think a lot of times it's promoted that way. That's like, oh, this is just, it's just perfect. It's not. And be kind to yourself through this. And also know that we are very much, and we're going to talk a little bit at the end, behavioral health providers really can make a huge impact. So we always like to say, if you're on the cutting edge, you're probably going to get cut. It's important to stay on the cutting edge, then also be kind and gracious toward yourself, because there will be cuts along the way.
Taylor and I have this saying that if anybody tells you that integrated care is easy, they've probably never actually done integrated care. So again, just want to reinforce this idea that there are tough days, and we actually aren't parents, but for those of you parents out there, this is probably shows that we're not parents. But it's like, if somebody were to say like about having kids, oh, it's the greatest thing ever. Well, most parents know that there's the highs and the lows, and there's the tough moments, but they would normally say it's worth it. That's what the majority of parents that I've talked to say, well, oh yeah, there's this and this and this, but it's worth it. I kind of feel like that with integrated care, because it's like, well, why would you do this if you feel like on the bottom right all the time? And it's like, well, it's not all the time. There's those joyous moments. And when you are able to help somebody or get the system upskilled in a way where more patients are being able to get the care that they need, I mean, it's indescribable. So that's why we're here, is the mission of that. So our agenda for this particular webinar is that we're going to talk about the mission of primary care behavioral health, and really integrating, well, again, this is from our lens of what we think the mission is of integrating behavioral health into primary care. We are, of course, going to talk about context and compassion, and review a little bit of the markers of a successful program. So I think that, we got to give Jeff Ryder credit for this. Many of you may have seen the Blue Book with Ryder and Robinson, but Jeff Ryder always talks about that integrated behavioral health, as much as it of course contains behavioral health. For him, the key component is making primary care better. And we have really kind of taken to that, and realizing that our mission when we walk into that clinic every day is not necessarily about getting more behavioral health to people per se. It's about making the system in primary care to function better. That a lot of times comes in the form of me doing behavioral interventions with a patient, but sometimes it's helping the whole team become more behaviorally savvy and realize, oh, hey, I think there's something else going on here. And actually to help from our reception team to our MAs to our clinicians and physicians, nurses, to develop almost that sixth sense, that spidey sense, as Dave and I always call it in our clinic, that there's something else going on here, and it has something to do with why their diabetes isn't under control. And sometimes if they don't have time to get into it, they can get a BHC involved, and it's just about kind of getting that whole picture of a person.
And I'm so glad that you're saying that that way, because, and let's also emphasize, we're coming from a primary care context. We could very easily change this to, if you're working in a medical specialty or whatever it is, that really you need to understand the context of what you're going into.
Right.
And that's where it's interesting. I don't even know how much I really identify anymore as a behavioral health provider. I more identify as a primary care provider, because that's the context that I am in. And while, yes, we pull some data, about 55 to 60% of what we get referred for is related to mental health. There's a huge chunk that is related to physical health and more kind of behavioral,
relational, sleep.
And that's the big thing, that it's not about just taking my skill set and helping people with mental health conditions. It's about taking our skill set and helping primary care do what primary care was set up to do. And we wouldn't be good contextualists if we didn't understand the context from where we're going in. And we always like to go over the primary care behavioral health model, GATHER acronym, of being a true generalist, and that meaning that you're seeing all ages, from birth to death, womb to tomb, whatever feels better. There was someone came up with a better saying. I forget what it was. Both of those I always get a little bit worried.
And this, to help put this in context, it helps if you think about like a primary care provider or a family physician. They're going to see, you know, they're not going to, if you call up with a concern, they're going to see you for that. So having that generalist approach.
Obviously, we want to be accessible. And again, this is another thing that's reflective in primary care is that we want people, if they need help or if they need interventions, we want them to get into us immediately, to be accessible. And obviously, this gets synonymous a lot of times with warm handoffs and same-day visits. But really, it's just about being accessible to the entire team, which leads into this being team-oriented. We want to sit with our medical teams, which again, COVID is an interesting thing that has caused us to have to rethink things. We haven't actually left our clinics as far as our workflows, but it's a thing that we always want to think about. How do we stay engaged with the team no matter what's going on? We want to be highly productive, and we always like to pause in this one because anytime we talk about productivity, and particularly with providers, I was doing a presentation the one day, and I said, who's sick and tired of hearing about productivity? And everybody like raised their hand, and they're like, they could tell, it's like, oh, I'm gonna like this guy. It's like, well, you're probably not gonna like me that much, because the thing that we really like to focus on is that high productivity means about serving our community, serving our patient population. And to do a population-based health approach, we need to see a lot of people to be able to do that.
Again, the same way your primary care provider, they're gonna see in a day, I mean, easily 20 patients.
Absolutely.
And so,
and we're not saying that the BHC should see 20 patients.
No, just the idea that it's really hard to be uptaken into a system when everyone's running around like a chicken with its head cut off, for the good and the bad of that, and making sure that everybody's seen. If we're in a separate office, dim-lidded, quiet, seeing 3 patients a day, and I'm not trying to, we said we were going to say some controversial things, so there we go. I'm not trying to put anything, we're being recorded. I'm not trying to put anybody down or put anything down. I think everything has its place. And the reason why we're talking about primary care specifically, where the biggest concern across the country a lot of times is shortage and not being able to have a place that you can go and get your medical and mental health care. And if you're especially looking at mental health care, is the biggest issue most of the time is just lack of access. And so if I'm only taking care of 3 patients a day, I'm just not providing my community the access. If I'm working in primary care, if you're doing private practice and that's your gig, that's fine, because you're not saying, hey, I'm primary care. You're doing your doing private practice, and we need that, and that's not wrong. But in the context of primary care, there's a lot of folks who need help, and they need help now.
You know, hey, we're rolling, right? So we might as well just keep going with it. I think this is where, to us in a lot of ways, this is such a value of us, and it's also a social justice value for us. We have to remember, in the past year, about 7% of the United States saw some sort of like outpatient mental health therapist, whether it be a psychologist, a marriage and family therapist, whatever it might be, a social worker. About 7% of the population. To us, that is just unacceptable. And a lot of times that's due to what Bridget was saying. I mean, there's a lot of things that gets in the way: insurance coverage, parity, access, whatever it might be. But this is one of our values, is that we want to serve our community, and we want to make sure that, and one of the ways doing that,
7%.
we want to be an educator. So not only an educator to our patients, but we want to be an educator to our entire clinic, as Bridget was saying before, about making our entire system more behavioral savvy. And we want to make sure that we're routine, whether that be through making specific clinical pathways, whether that be making sure that BHC leadership are a part of leadership throughout the system. We want BHC to be the expectation, not the exception. The other thing that we really try to go over is the idea of what is primary care. And this was a big learning point for us. I remember us, we had specific grad school training in this. We had an internship in this. We had a postdoc in this. I had never really grasped, though, what the purpose of primary care was. I had seen it through my clinical experience, but never really able to articulate it about what the purpose of primary care is. And one of the great ways that I heard at a conference one day of primary care being summarized is through the 4 C's. And the 4 C's being, 1, first contact with patients. So we want to be able to have patients, going back to that A in the GATHER acronym, to be able to access us when they need it, to be able, or access us when they need it. That if something's coming up and they need to go to someone for the first thing, they come to primary care for the first contact. Continuity of care, obviously that goes back to being a generalist, that you're going to see patients throughout their lifetime and have this continuity relationship. It's something that we get so excited about. I feel like we're the only behavioral health providers in the country or in the world that gets to have a relationship with our patients throughout their entire life. Like, how cool is that? That is such a cool
Yeah, there's
thing.
no start or stop.
No, because we're primary care. We have continuity throughout the lifetime. Providing comprehensive care, that again, going back to that generalist idea that we see everything and anything, that first contact for most things happen within primary care, and then we coordinate care when needed. And one of the big things we always try to highlight with coordinated care is just like when a primary care provider maybe is working with someone who has diabetes that continues to be uncontrolled, and they might refer that person to an endocrinologist. They don't stop seeing that person though. The primary care provider doesn't be like, all right, well, whenever you're done with the endocrinologist, come back and see me. Primary care provider still sees them while they're seeing a specialist. And that's the way we look at this as well.
So I just want to take a moment to say that, like, in none of our, we had specific training in primary care psychology, and this was not explained in this way, not through anyone's fault, it's just so brand new. But this idea that sometimes people will say, well, I don't really get it. Sometimes if you're doing, if a patient wants to talk about maybe some trauma or something they went through, aren't you now doing counseling so you're not doing integrated care? And so it gets into this huge thing about, like, what is integrated care and what are interventions? Is it just brief interventions? What if it looks more like counseling? And then do I become their counselor? And what if there's not specialty mental health access? Do I now become their therapist? This is why we have on here the litmus test. If you're like, I don't know if I'm doing primary care psychology or primary care behavioral health right now, I'm confused about this. If you are seeing patients of all ages, of all kinds, for all conditions, you're accessible, you're involved in a team, you're seeing a lot of their patients, you're helping the team get educated, it's not seen as, like Dave was saying, a big exception that you're involved in the care, and you are helping a person on their continuity, their longitudinal relationship, that if you're doing those things, whatever it looks like in the room, whether it's a little bit more Rogerian or a little bit more CBT, what matters how you're doing primary care behavioral health is if you're following, gathering the 4 C's more so than what it actually looks like in the visit.
And what's really neat about this is that we've been at our clinic now for almost 6 years. Some of the continuity that we have with patients, especially since we're a residency program, we have residents obviously that rotate in every 3 years. We're the ones that actually hold that continuity a lot of times with patients. And it's a really cool thing because a lot of times we get the almost leech off of the primary care provider's relationship and the rapport. Now, a lot of times with our new residents coming in, we're able to build up these new residents with the patients. Say, hey, this guy, this person is great. You're going to love them as a provider. We're going to be here with you, and it allows that both that continuity and that rapport to be built.
And so this next aspect about kind of, how as a BHC you want to go into your clinical work, and we got this from Focus, Acceptance, and Commitment Therapy. And that's third wave cognitive behavioral therapy, a book that was written by Kirk Strassel, Patty Robinson, and Thomas Gustafson. They say that the core assumptions of a BHC going into the visit is essentially that you're going to help people right then and there, and hopefully, as we know, start getting something done before some patients' natural tendency to quote unquote drop out. Now, the cool thing about primary care is even if they drop off seeing a BHC, most of the time they're still involved in their medical care, so you can try to snag them at another time as well.
The one thing, and I know we're probably doing horrible on time, but the one thing that I also wanted to say about this dropping out, kind of remember, as we all know these stats, it's always one thing that we don't really adapt to it. Oh, is it in here?
Yeah.
Oh, never mind. Yeah. Never mind. Go ahead. My bad.
So we want to start that change process now. If you look at the motivational interviewing literature, they're going to say the same thing. So when the problem bubbles up so much that somebody's reaching out for help, and then we put them on a 6-month waiting list or a 3-month waiting list, or we go and we do a meet and greet and we say, hi, I'm the behavioral health consultant. Do you want to come back and schedule with me in 2 weeks? Again, I'm not being judgmental, but we got to start thinking this through, that if this person is here now and they gathered up enough nerve to ask their doctor for help, and they allow the BHC to come in, and then we're going to schedule them out? No. I don't care if they say they have 5 minutes. They're just saying that because they're trying to feel you out because they're scared. And if you go in and 99% of the time, if you just get things going, then most of the time I'm like, oh, don't you got to go? They're like, oh, no, I'm fine. So start that change process now is the main point.
And the one thing I wanted to say about that real quick, I really like what you said about this person was brave enough, courageous enough to say, hey, I need help. They were brave enough and courageous enough to say, yeah, you can bring in a team member. We, at the very least, have to reinforce that behavior. I mean, talk about from an ACT kind of perspective that they were willing to expose themselves to uncomfortable thoughts and emotions towards their values, and then we don't reciprocate that in a sense, like we don't like try to build that up. And that's a big thing, a part of that. On the very subtle way, regardless of the intervention, if you stay with that person and try to help them right now, it reinforces them for their willingness to ask for help, which is really cool.
I won't go too far in, just for time's sake, but talking in rapid change terms. So that's looking at the literature and showing that some folks in those first 4 sessions make really big leaps. And kind of a large proportion of folks, if you meet them where they're at and you get something going, they're going to see gains. The other thing you look in the literature is the watchful waiting. There's a lot in Europe where their intervention sometimes is no intervention. And I think that BHC in some ways can be the best thing for that. So what I mean by it is somebody comes in and it's for depression. If we don't understand their context, we might not realize they just went through a breakup. So we can go ahead and get them started on SSRI, or the physician gets them started on SSRI, maybe sends them to counseling, does all these things. And it turns out that in a few weeks, they naturally are getting better because the issue that they're coming in for was so absolutely situational. So a lot of what the BHC does is on that day when we go in, which we'll get into the contextual interview, we're going to ask questions to figure out what's going on in their context. And sometimes that gives us just enough whatever to say, all right, we're going to keep an eye on this. We got a couple of intervention, a couple of things we're going to try to move us in the right direction. Come back and see me or the physician or both of us, or staggered in 3-4 weeks. And we're going to reassess this. And if it's still an issue, we can maybe try another behavior. If it's still an issue, we can try a medication. So doing kind of like watchful waiting out of the European research is really cool.
We're never going to get through these slides because I just have so many things that come up for this.
Reel it in.
But I do think one of the things that I would call it almost active waiting. And a lot of times the literature calls it watchful waiting, but I think it's active waiting because you still do some interventions. One of the more subtle things that I think come from that, and what we should be doing more, is it normalizes what our responses should be. You mentioned about like a breakup, that someone comes in and we give them the PHQ-9 and they max out the PHQ-9. And if we don't ask any questions like what's going on with them, it's like, we're reinforcing to a whole slew of people that, oh yeah, if you're ever depressed, that's a really big problem. Where if you just broke up with someone, or if there's something that was going on recently, or if you had some really difficult things throughout your childhood and depression showing up, that's expected. And I think that's one of the really great things that we're going to talk about with the contextual interview, is that one of the nice things and subtly that it does, it reinforces to people, yes, this is a normal part of human existence. That's not something that's broken about you. Sorry.
And, as you all probably learn in graduate school, the mode number of visits is 1 for psychotherapy, just in general, just like across the board, no matter what setting you're in. And so we have to kind of go into the very first visit, assuming that this is probably going to be your last and only visit. And I think if you do that in general, you come in laser focused, you come in and you're able to get something done, like Dave was saying, that's going to make that relational frame in their mind, that association. Oh, just like if I have a cough that won't go away, or just like if I have a pain in my knee and I go see my doctor, we come in and we get something taken care of. I had this issue, I had some stress. I came in, we got that issue taken care of. That's where I can go when more issues come up. And then just real quick, we got to be humble about knowing who's going to make rapid changes and who isn't. So even folks with long-standing problems, we can't assume that just because they've dealt with depression for a long time, that, oh, well, I'm in integrated care, I can't help them, they need to go see a therapist. Do not make that assumption, and vice versa. If somebody's kind of coming in and it seems like they got a few mild issues, we don't know what's bubbling beneath the surface. So just be humble and saying, we don't really know what's going to happen. We're going to experiment. And if somebody needs a higher level of care, we'll find that out and we can get them there. But there's a lot we can dang do in primary care. And so we want to draw on these active ingredients of primary care. Again, Dave and I were talking with Jeff Ryder recently, and I was just asking him, I'm like, what do you love about primary care? Because that's what that's like his mission. And he's like, I was like, what are those active ingredients? So we just had a conversation. And if you look at the way primary care is set up, it's this longitudinal relationship. Once again, training as a psychologist, we are trained to do therapy. You have an intake. You go through all that process. You have an end date and discharge process. Termination. Primary care, this is over the course of a person's life. And if you work in a system long enough, we've been in the same system for 6 years now, we've got to see kids turn into teens turn into young adults turn into parents, all these different life cycle things. And it's really interesting how well you get to know them and get to know their family. And like I was saying before, that practical nature of it. Oh, you need something, you come to see your doctor. Oh, you need something, you come to your doctor's office, you see your BHC. That, again, that association, integrated care is not about brief interventions in the sense of that, oh, we're really focusing on the brief.
You know, I want to tell a story about, because this actually just happened yesterday. I met with the patient for the third time over about a 2 months period. She was at the beginning of the handoff. It was difficult. She had a lot of things going on, a lot of ACEs, a lot of different hardships and whatnot. What was really interesting is that she did well at the follow-up visit, and then this last visit, she was doing extremely well. But it was such an interesting conversation. She was almost not wanting to say that she was doing well. And the reason why, and she actually said it, was, well, I really like our conversations. Like, I don't want this to end. And I told her, I was like, look, we're primary care. This is never ending. You know, if you keep doing well, we might move to as needed, just like you would for your primary care doc. If you're starting to do better, if you don't need to come in, that's totally fine. But we're here for you. If we're saying, hey, follow up as needed, and the next day you're like, oh, I need to get in to see them, get in to see us. It was such an interesting moment because of that longitudinal relationship that we have. But a lot of people don't know that or don't experience it that way.
Right, and they think, well, hey, we got to be quick, we got to be practical. So somehow we got to lose our deep connection and our rapport and our knowledge. And I don't think that that's necessary at all. In fact, one of the biggest things that we hear for a barrier for why folks don't want to move to integrated care is because they're like, well, I want to keep a longitudinal long-term relationship, and I get that with therapy, and I don't get that in integrated care. And I'm thinking, well, maybe if you're not doing integrated care, but anyways, I digress. But the point being is, if you are doing integrated care, you want it to be deep connection. I mean, it's not like Carl Rogers and all these other folks that we learned about. Yeah, it goes out the window because we're in primary care. Now, I say that, and now I'm going to talk out of the other side of my mouth. We can't have 50-minute rapport building sessions where the only thing we're doing is building rapport per se, which actually is a perfect segue into the contextual interview. We have to change kind of some of the structure. And yeah, we're not going to be meeting for 60 minutes once a week unless there's a really interesting.
Because that doesn't fit along with this like population based.
Yeah, you're not going to be able to reach people. You're going to be filled up. You're going to have a 10-month waiting list before you even know it. So yeah, we're going to have to do things different. But doing things different does not mean you're not making a connection. And one of the ways that we've iterated from Real Behavior Change in Primary Care, written by Patty Robinson, Deb Gold, who's a physician, and Kirk Strassel, also a psychologist like Patty, was from the Real Behavior Change book. They talked about love, work, play, and that you want to do a life context assessment when you walk in the door, again, laser focused. We have taken that same concept of the love, work, play and just made a few little iterations to it. And the reason why, it's a long story, I won't go into it, but we were trying to teach our residents to do it, and we realized we needed to be very, very specific. So we couldn't just say, hey, figure out who's in the home and what their relationship status is. We had to be very specific about it, which then we actually really liked this idea that when we walk in the door, I'm going to introduce myself and I'm going to get rapport within the first 7 to 9 seconds, the same way the physicians do. So as much as medicine can steal a lot of stuff from behavioral health can steal a lot of stuff from medicine. The primary care provider, when they walk into the door, they know that they're going to help that patient. They're going to get something done. We, as a behavioral health provider, need to not be as obsessed with this idea that it's all or nothing. We either make their PHQ score goes from a 27 to a 5, or there's no point of meeting with them. Like, no, there's always something you could get done. So when I walk into that room, every time I'm meeting with somebody for the first time, I am going to do a life context or contextual interview, as we call it. I'm going to sit down with that person. I'm going to give that 1 to 2 minute introduction. And I'm going to say, I want to get to know you. So I'm going to ask you some questions. So before I even get into all these other things, I'm going to say, who all is in the home? Okay, so your husband lives in the home. How long have you all been together? Oh, you've been together 10 years. Would you say this is a supportive relationship or, you know, up and down? Oh, it's supportive. That's so great. Who's in your family? Like, who's your, and I always make a joke about like Meet the Fockers of who's in your inner circle or whatever. And I'm like, who's in your inner circle? What family members are dear to you, essentially? So we go over that. And then I say, you know, we talked about family. Any friends kind of make it into your inner circle. And then as far as this, their spiritual life, is there anything that you do to connect with your religion, your spirituality, philosophy? It doesn't have to be religious if some folks aren't religious, and your community. So once again, we're getting that snapshot of who does this person love? And then we move right into work or school or income, because we got to figure out kind of what the work, school, income situation is. And then we move right into what do they do for fun, hobbies, relaxation? Do they have any things that they have a passion for? Working with Kirk Strassel, one of our mentors, he said, how are you going to help somebody if you don't know what makes them tick? And that's what this contextual interview of love, work, play is doing. It's figuring out what makes that person tick. What is the most near and dear to them with their relationships, their career, their passion. And then, of course, I think health behaviors is always important, from doing that diet, exercise, sleep, to the caffeine through substance use. So this is the interview we do with every single patient, every time.
And what's really interesting
Or
about it is that
new visit.
when you have kind of when you get through this love work plan, you get to learn about the individual and what makes them tick, their background, their history. You start to see almost like their internal context, like how they see themselves, how they see the world. And then and again, this is why, you know, our minds are always making assumptions. You can predict pretty accurately like what the health behaviors are going to be. Learning about the love, the work, and the play, you can start to predict, does this person have or engage in any healthy activities such as exercise, or what's their sleep? Obviously, we still ask the questions to make sure our assumptions are correct, but it's a really great thing that we know is true, is that all these behaviors such as diet and exercise and substance use and the life engagement are rooted in the person's context. They are derived from that.
I have a quick example.
Yeah.
So we have this really cool OB pathway in our clinic, which essentially means any person who's newly coming in for OB visit, they'll meet with the nurse and then they'll meet with the physician. Well, now they're automatically bringing in the BHC. And so when I go in,
There we go.
just like any other
Thank you,
visit,
ma'am.
You're welcome.
I'm going to do a contextual interview. And so there was this woman who found out that she was 4 or 5 months pregnant, didn't know about it. And she was very distraught because she's like, with my other 2 pregnancies, I made sure I didn't have, you know, more than 1 cup of caffeine. I made sure I had 0 alcohol. I did all these things. And now, like, she's not a big drinker, and she's not, thank goodness she doesn't smoke. And she didn't do that much caffeine, but she's just beating herself up about it. So if I would have taken it on the face value without doing a contextual interview, we probably would have talked about some guilt of, you know, in the adjustment to finding out she's pregnant. Well, I do a contextual interview. The 3rd question on there, after the living situation and her husband was there and her relationship, the 3rd question is family. Would you not think the day after Mother's Day, I asked, well, who else is in your family? And I see her eyes starting to kind of like well up. And I know I'm onto something. And she says, oh, I don't have a relationship and I never have with my dad. So I kind of thought, well, maybe it's those adverse childhood experiences. And so this is scary for behavioral health folks, I know, and actually for medical providers. She mentioned her dad. She didn't say anything about her mom. And so I said, and your mom? And she starts crying and she says, my mom just died. And she, like I said, she has 2 kids already. She just found out that she's pregnant with this 3rd one. And her mom died on March, whatever, 20th or something like that, of this year. And she said, yes. And this was the day after Mother's Day that she's having this ultrasound. So just imagine the big piece of the story and the big piece of what we need to help her with as just healthcare providers. And she said she didn't want to talk about it, and I honored that. But that piece of information was crucial to understanding what we needed to give her that day. And I was able to work some stuff in about grief we were able to talk about it without talking about it. You know what I mean? So it was just one of those moments on that third question. If I would have taken the surface level, what she was in for, it's like, oh, well, this is perfectly healthy, blah, 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 blah. Sure enough. So go ahead, Dave.
And I think it's such what a tell about this, because as Bridget was saying before, we do this contextual interview with every new patient that we meet every single time, and we do it in the same order every single time. Essentially, for me right now, and maybe it's I don't know, my mind is actually saying, yeah, this might not be a good thing, but I feel like I can't intervene with someone unless I know the context. Because again, being a contextual person, we know all these things, including, and especially the research that we know about ACEs, social determinants of health. We know lifestyle. So even if it's diabetes management, even if it's hypertension, even if it's someone who's having a difficult time taking a medication, so the treatment adherence, we know those behaviors are coming from a context. There's a reason. People don't wake up one day and think, hey, you know what? I want to be a jerk today, and I'm not going to take any of my medication. Like, we know
I want to really upset my medical provider by being non-compliant.
And I'm going to come in and tell them about it, right? That just isn't what people do. This allows us to understand that context. And the other thing that it really reinforces, I think, very subtly, is that, yes, I am interested in what your presenting concern is. What I'm more interested about is you as an individual, because you are not
Constellation of your symptoms.
Yes, a constellation of some of your symptoms. You are an individual that I want to learn about.
And one of the coolest things about doing the contextual interview is we got so reinforcing to our medical providers that when they come out for a referral reason, instead of it being the referral reason, depression, anxiety, diabetes, grief, their referral reason oftentimes is, can you do a contextual interview? Can you contextual interview them? Because there's something going on, and we've been trying to work on the diabetes, and everything we're doing is by the book, and it should be working, but it's not. I think there's something else going on, but I ran out of time today. Would you be able to contextual interview them? Or sometimes they'll come out and they'll say, I contextual interviewed them, which I think is amazing, and I found out this, this, and this, but I don't have time to then intervene, so can you go and do it?
And that's the one thing that I'm so glad that you highlighted as we make this transition to the next slide, is that we teach our medical providers this, and we put up the contextual interview questions all around the clinic to really reinforce it. It's a verb now. Our medical providers are starting to do this, but sometimes they just don't have enough time. And that's where hey, can you please go in there, as Bridget was saying, contextual. And what this allows us to do, and this is one of those things that I think is I'm so glad that you said this at the beginning, Bridge, about this idea of when people make this transition to work in integrated care, they're like, I feel like I'm losing who I am as a provider. I feel like I'm losing my identity as a mental health. Like, I want to have a relationship with a patient. I want to be able to connect.
I want to see how it ends. That's what a lot of the new behavioral health consultants say, is I don't get to see how this ends.
And what this allows us to do is it keeps us curious. It keeps us interested in what is going on. It allows us to have, as Bridget was saying, that humility, that we want to make sure we know what's going on in their context. It allows us to have interventions uptake. I had a resident the one day. How are we doing on time?
You know what? It's 6:41. I extremely want to hear what you have to say, because I actually haven't heard this story, I don't think. So it's 8:41 for you all. It's 6:41 for us, Pacific time. So that means we got 19 minutes left. I wanted to pause and see if anybody had any questions or put anything into the chat, just anything that we've said so far that you'd want us to expand on, or make sure that we hit in these last 19 minutes so you get what you need out of the webinar. And we can continue on, and we can keep our eye on that chat box so that we don't have to put anybody on the spot. So why don't you kind of continue with your story? I'll keep an eye on the chat box, and then when you're done with that, we can move around.
I was working with a resident one day, and they went in to see a patient. It was a grandma who also had their grandson in, and they were of Mexican heritage, and she only spoke Spanish. And we had an interpreter room, and she had diabetes that was relatively uncontrolled. And so the resident, going in there very accurately, and if you look at the algorithm for diabetes, said, hey, you know what, I need you to make some changes to your diet. You need to stop eating rice and stop eating tortillas. And what was amazing about it is that the patient said, okay. And the grandson, I was so proud of him, he's like, yeah, that's not gonna work. And it wasn't going to work, not just because what we were asking her to do was literally remove a vast majority of her diet that she eats. But what it wasn't going to work is what the grandson said afterwards. He said, listen, my grandma, she's a matriarch of our family. And the way we socialize is through food. You're literally like, and he didn't say this exactly, but what it was derived from, you're literally taking away her lifeline. You're literally taking away her value for this. And that's where this is always a context from where this is coming from, whether it be diabetes, whether it be hypertension, whether it be depression or anxiety or trauma, whatever it is, there's a context that's shaping it. And when we get this context, now we're not going to ask this person to do essentially, and I say this in a colloquial way and somewhat of a humorous way, but then also serious, we're not going to ask them to do dumb stuff. We're not going to ask someone that we know isn't going to not cut out rice completely or not cut out tortillas completely. And then when they come back in and they didn't do it, we get mad at them for not doing it. It makes our interventions uptake from the patient.
I have one other really quick thing. I want to continue on, but I had this, I was working with this physician and he was awesome. He had every evidence-based like recommendation memorized to the T for not just medical things, but for behavioral things. And this one 17-year-old he was working with was dealing with, you know, increase in weight, and then she was becoming having prediabetes. And so he came in, it was so cute. He had like this like self-monitoring like log of like how she was going to exercise for 150 minutes and how she was going to start self-monitoring all of her food intake and writing it down. And he like printed out all these handouts for her, and he had this big packet. And then he also wanted me to go see her kind of as well, because he was running out of time. And so he like gives me this packet, tells me all the stuff he went over with her. Sure enough, I do a contextual interview. Turns out the 17-year-old, she's in like the advanced classes at her school. She's a senior, so she's about to graduate. She lives in a home with like, she has like 3 or 4 family members who have special needs that she has to take care of because her parents work all day as migrant workers. So they're working like 12-hour days. And then she also has little siblings that she has to watch. So the things that he wanted her to get up and go to the gym before she went to school. And then after, I can't even remember what he wanted to do after school. And this 17-year-old, she literally has to get up her younger sisters and brothers and sisters and get them ready in the morning. Then she has to go to these advanced classes all day long at school. She has to come home and make dinner and take care of her family members who have special needs so that the parents could then get home. And we're gonna ask this person to just automatically work out for 150 minutes and log everything that she eats, and she's 17 years old. Like, we just gotta think about it.
And what happens, and the ripple effect of this is, one, maybe she comes back and she wasn't able to do the ask. We then label her as not adherent. We label her as being like, yeah, you just can't do this. What I think actually happens more often than not, though, is people don't come back.
Correct.
Because they don't want to disappoint the medical system. They don't want to disappoint their doctor
They don't
or the
want to go step
BHC.
on that scale and see that it went up this time. And if we don't ask those questions, then we don't know what we're working with.
And that's why this doing a contextual interview and leaning in, it allows patients to engage with us. It allows them to recognize, like, they understand that we're seeing them for who they are. And our interventions are reflective of that context.
And that's, oh, good.
Okay.
That's another thing that we use the contextual interview for. I always say, everything you need to know about the intervention is sitting right in front of you. We just have to ask them, because if you understand what a person, you know, with the relationship and their work status and their school status, what they like to do for fun, what they've done in the past, what they do for exercise, you don't have to then think of an intervention. It's not like, oh, I did my assessment, now I have to come up with an intervention. The intervention is right in front of you. People will tell you, well, I was walking, or I was going to the gym, or I was doing this thing, I was doing that thing. Low-hanging fruit, guys. Pick something that that the person has already done, and then problem solve around that. So when you do the contextual interview, it's not just about, well, I'm doing the assessment and then I'm going to move into the intervention. That whole thing is the intervention, and you can call from that what the intervention for that day needs to be. And it doesn't always need to be psycho-babbly. It can be something as practical as, what is one thing you can do that brings you closer to what's important to you?
Absolutely, absolutely. One of the things that we also, and this came from one of our interns, this idea of reverse engineering, is what if we started to, before we went into every single visit, before we went into every single exam room, what if we all started to ask ourselves, how do I want this patient to feel when they leave the room? And one of the things that I love is that doing the contextual interview allows me to achieve what I want the patient to feel, which is I want them to feel loved for, I want them to feel a sense of grace and a sense of compassion, and a sense that another human being understood what they were going through. That's what I want the patient to leave with. And again, what that turns into is that they engage with us more. And we always ask this question, what would happen if healthcare became just 5% more loving, more compassionate, more curious? Doing the contextual interview and being curious about what's going around this individual, like you were saying, that's an intervention in of itself that accomplishes that allows compassion, love, kindness, engagement to be fostered.
And if this is kind of a little bit difficult because it kind of maybe feels like we're talking on two sides of our mouth. In one way, we're saying we need to get in there, we need to be laser focused, we need to have 25, 30-minute visits because we need to see a lot of patients. And on the other hand, we're saying, hey, you know, love is everything. We need to get the, you know, it's all about the deep connections. It's Carl Rogers all day, every day. I understand it sounds like we're talking on two sides of our mouth, but I don't, or and it's nuanced and you can do both. It does take practice, but you can do both because if you go in laser focused with regards to, I am here in this moment and we are here to get something done. And in order for us to get something done that's meaningful, I need to know you. So if you're, again, you're going into the room, I need to know you. I want this connection. You want this connection. Out of that is you're going to get something very practical out of it because you get to know their circumstance. And so it's both and it's and
that's where this is what we wanted to end with, because I think you're absolutely right. Like we're talking out of two sides of our mouth here. It's like, wait, you want it to be like reflective of primary care, but you want me to ask all these questions. And the one thing that we are very passionate about is that you have to have data to back up what you're doing. One of the things I think is really unfortunate is that we ask people to do a lot of things that we don't necessarily have data to back up. And one of the things that we know through our system, every one of our BHCs does the contextual interview. I mean, our notes are literally, you can't do a note in our visits without doing the contextual interview. Our patients' visits per day or per clinic is around, especially in April, is about 10 patients. And this is actual legit stats. I always get wary when people are like, yeah, I think I average 10 patients. Like, no, like maybe one day you saw 10 and then the next day you saw 5. So again, you're at 1.5. But the visits per day per clinic for our system is around 10. We average about 1.5 per BHC or 3 handoffs per BHC per day. And usually we have 8 BHCs that will be on throughout the day. So that is upwards to over 20 handoffs are occurring throughout our system each day. We serve unique patients. We, this past year, have served 20% of our whole healthcare organization's patients in the past year has seen a BHC. That's all a medical provider as well. At our mothership clinic, 24% of our, which is where Bridget and I work, 24% of patients who saw a medical provider in the past year also saw a BHC. Our patient satisfaction, and this is the thing that's always great, you know, we average about 2 visits per patient. And I always get this question, well, patients can't like that. And, you know, we see patients for about 20 to 30 minutes. Patients can't like that. Our patient satisfaction is the same or better in every single clinical experience or patient satisfaction experience compared to state, regional, and national averages. Our medical provider satisfaction, the past 2 years, we thought it couldn't get any higher, and it keeps getting higher, right? It keeps getting higher. And one of the things that our provider said this past year, he said, primary care behavioral health is the single best innovation in his entire career. And this is coming from a medical provider saying that. The last thing that we wanted to end on, because we know we have some payers in the room as well, we're seeing some really interesting things as far as what patient outcomes are after they see a BHC. Things that we get graded on as a healthcare system. Diabetes control, hypertension control, wild child visits, wild child vaccine, or children getting their vaccinations, as well as just general patient experience and satisfaction with the clinic.
We get with our clinic and go over with the leadership and say, what are the clinical aims and goals for the organization? And then once we know what that is, we can then look at as BHCs and say, all right, how can we impact that number? So I really, I'm glad that I cannot believe we ended
okay. And
8
I wanted
minutes.
to make sure we made it obvious that all those clinical outcomes and measures after they see a BHC go better. Even through the things like
diabetes goes down.
Diabetes goes down, hypertension goes down. But what's really interesting is things like reception staff courtesy, pharmacy. It's the same people, regardless if they see a medical provider.
People check in and check out. Like there's no difference if you're going for a medical or behavioral health visit. But the surveys where they're filling it out on the behavioral health provider, they rank them higher.
So on days that they see a BHC, they rate reception staff courtesy higher. They rate pharmacy engagement higher.
And Patty, that's a great question. We are a one-trick pony. For what do we do with physical health problems like diabetes to make a change in that outcome? We absolutely are doing that contextual interview, and we're trying to figure out what aspect of it is there barriers. And so if you know a person's if you can imagine what it's like for them to wake up and go through the course of their day, you're able to join with them in a way where you're going to make a goal that is actually realistic and feasible. So you can truly do a SMART goal, and make it specific, measurable, attainable, realistic, and time oriented. So if you're able to imagine what is a day in the life of this person, when you go and start saying, all right, what can we do to get started? You're going to suggest something that A, they've already said that they've tried, or B, that they did in the past, or C, you're going to give something realistic, because I would never ask that like 17-year-old person to just start, she wasn't exercising at all, to go do 150 minutes. I might start thinking about, well, while she's at school, can she go on a walk on her lunch, during her lunch? So you're making more realistic, more feasible, and then it's increasing that engagement piece.
I love that thing about the engagement piece. And the one thing that I approach every single patient when I'm going in is that, again, being a functional contextualist, I believe every single behavior that someone does makes sense within their context. So when I go in and someone's having a difficult time struggling with their diabetes management, I'm assuming that behavior makes sense within their context. So I'm not going to just try to throw out a bunch of interventions because that behavior makes sense that they're struggling right now. We got to figure out why they're struggling.
And that's the magic. If not, a talking monkey could do, you have diabetes, here's this algorithm. Oh, here you have headaches, here's this algorithm. We have to have both. We have to have the intimate knowledge of what do you do with headaches, what do you do with diabetes, but also use yourself as that clinician of figuring out that nuance of that person's situation that is really impacting that.
Patty, I think you asked a really good question about how do you make your program financially sustainable, and we actually just got our budget again yesterday, and you're not gonna give me a high five?
Oh.
Just leave me hanging right now.
I thought you were doing a metaphoric high five to the audience.
But so the one thing that I think is very clear, these behavioral health programs that are integrated, they're going to be supported by a bunch of different financial streams. Without question, grants are probably going to be a part of that conversation. The thing that we've really hit, productivity, we go over productivity. We'll have our BHC monthly meeting actually tomorrow, and we go over productivity every single month. And the thing that we try to really emphasize is that this is something we're going to track, not only just for the financial realities of the system that we're in, but that this reflects our value of being a behavioral health provider within primary care, is that we want to have high productivity. This reflects the value. And the thing that we know, and we're lucky because we get to work in an FQHC, and we're very fortunate that we work in the state of Washington that values mental health and integration and has really great pay parity, such as the fact that if you work in an FQHC and you're a billable provider like we are, we get the same encounter rate that our medical providers do for the FQHC. So our visits actually are just as valuable to the medical clinic as a medical provider's visits.
And I would say, because everybody, obviously is not in Washington and might not have the same scenario, I would sit down and figure out what are the funding streams coming into the clinic, and then really having that good awareness of what all the financial stream, and then where can you impact it along the way. So maybe it's a productivity. Maybe there's this grant that if you see this many patients with this condition, then you get this. So you got to know you got to know what goals are for the whole organization, get that bird's eye view, and then start to break it down. But yeah, this is an ongoing issue in the United States and in different setups.
And COVID has only highlighted that even more. It's an interesting thing that's happening, right? Everybody's talking about the next pandemic being the mental health one, which I totally agree with, but it's like, where is the action at? Where's the pay at for that?
Because they're going to do reimbursement for phone visits and
have a parity between what is medical and what is behavioral health, or I wish it was just one. What is health? What's the pay for healthcare? Other questions?
Yeah, we got three minutes.
I am going to put up this last slide as people maybe put in some questions. You know, we have a lot of different things to contact us. We have a website. We have a YouTube channel that goes through examples of what a contextual interview looks like with patients.
Yeah, I think there's 4 or 5 contextual interviews ranging from 17 minutes to 30 minutes, and that's the full, and it has an interventionist, from the
whole visit.
The introduction to the contextual interview to the intervention.
This always feels weird doing this, but we talked to Patty about it before. We do have a webinar series that will be at the end of the month. That will be live webinars, as well as people be able to watch them recorded, related to everything behavioral health, primary care behavioral health. It's a 4-part series, so you can check out the link. Obviously, reach out to us with questions as well. We love, as you could tell, I hope you could tell, we love talking about this. I mean, we could talk for days about this, but we hope this gives a little bit of a snapshot.
Yeah, and you know, you can follow us on social media as well. We try to post tips and tricks, and as you can see, our Facebook and Twitter is PCBH Life, so that's very apt and reflective.
Ideas for agencies best to check. Great question. You know, and this is one of the places that I would say I'm definitely not an expert in. You know, our organization thankfully has a grant kind of individual personnel who is always sending us grants if we think like it's going to be one that would be. HRSA is a lot of the places that we get grants from, but you know, we've had some different ones that even our what is it called, the Accountable Communities of Health in the state of Washington. It's a Medicaid program that put out some grants about a training program that we've been able to do. Yeah,
I'm realizing how little I know about some of the other states and their setup, because I know in our organization, our C-suite, you know, CMOs and CFO, they're on all these like primary care listservs, both nationally, regionally, and statewide, and then they'll pass a lot of stuff on. And then what I've noticed that it's both ways, because you know, we'll see things out on listservs as well. Through like Collaborative Family Healthcare Association.
Yeah.
But for each state, I think that would be very state dependent.
And Kim asked, have you noticed through your trainings, primary care clinics are willing to do this with current health and behavior codes? So yeah, it's a good question about codes. We use health and behavior codes, we definitely do, and we use psychotherapy codes as well. One of the things that Bridget has had the foresight to have is really working with our IT department and our EHR department on coming up with templates to make sure that all the billing requirements for using those codes, such as psychotherapy and health and behavior, are met, and we try to make it as easy as possible. And our VHC is like, hey, you just need to make sure that you're clicking all these boxes and you're addressing these things in the visit to make sure that we're billable. So what we have heard in response, health and behavior, we've been able to build. It's an interesting one. They didn't like obesity and a lot to get reimbursement, but for a lot of different health concerns, we've been doing well.
And like you're saying, I would get with your organization. So if you're working in a medical center, whatever the medical billing encoders are doing, they almost have to take it over, because it's like a full-time job just trying to figure that out. So we rely heavily on our team, and by our, I mean like the medical center's team. So there's not like, oh, well, we have our medical center and this person's doing medical and this person's doing behavioral health. At our organization, the billers and the coders, the billing encoders, they own all services that are happening at our clinic. And I think that that's something behind the scenes that you might have to advocate for. They can't just say, oh, I only know medical, I don't know nothing about behavioral health. Like, that's their job.
As you can tell, Bridget, again, we try to be very intentional in what we do, and we try to make intentional friends, really with everybody, but specifically people like billers and coders. And
that makes it sound weird, but
oh, sorry, did I make it sound weird?
Well, you try to be intentionally friends. You try to be friendly.
I try to be friendly, but I definitely am going to be intentional with the people that I know that I don't know that information, and I need to have someone help me understand what's going on.
And I think more, in addition to that, is just letting them know, like we say all the time to our billing encoders, that their work is directly translating to us being able to help patients. And so it brings in their values, because a lot of them are like, well, we're doing all the stuff behind the scenes, we don't really get to do patient care, and they might kind of feel left out. It's like, no, oh my God,
you're vital.
Like, you are vital to this process. So bringing them in on their values. So it's not just patients we want to help connect with the values.
Charles, you're dang right. It's a great book, and there's a lot of great understanding. One time we asked Kirk Strassel, it's like, hey man, how did how did, primary care fit with ACT? And he was like, it was the opposite, man. He's like, ACT fit with primary care. And I think those things go hand in hand. And yes, we are definitely in a good state. We love our vineyards and our hop fields. It's been a really great.
Dave just bought a hat that said, what does it say?
Yakima, we make your, or we grow your beer. So thank you all for joining.
Thank you both for being there. This has been really great and exceeds all of our expectations. And one of the things that has continued to draw me to you are your brief training videos that are available on YouTube and other sites, and that you are always data focused and that you've got outcomes that you're focused on. And so, although it sounds a little touchy-feely when you're talking about love and all, but that's why we're doing this business, and to help suffering, and the fact that you can tie that to really improved outcomes, not just for mental health, but for all of healthcare, and that our focus is on helping primary care. So, so appreciate y'all and the resources you give us and how accessible you are to our communities.
Oh, absolutely.
Our gratitude to you all. Thank you for allowing us. As you can tell, even if it's we love talking about it.
We did graduate school in Missouri, so
we did.
Oh, not too far.
Yeah, not at all.
Springfield, Missouri, and so we have a heart in the Midwest.
Yeah.
Wonderful.
Awesome.
Thank you all for your time, for getting up so early and sharing all of your knowledge with Arkansas. We appreciate it. And hopefully at some point we could have you back.
Absolutely.
Anytime.
Okay, wonderful.
Thanks, y'all.
All right, see you
Great
guys. Have a good
day.
day.
Bye-bye.
Do you get the rest of that?
That was really good. I still see that we have a couple more people that haven't hung up, but Kim, are we confirming 2 o'clock Monday, you and I?
Yes.
Okay.
I've not pulled up my schedule on this, but I think 2 o'clock should work great. I've actually, it's interesting, a couple of things. So I got to see them with CHCW. They're doing a 20 series of webinars. And I've only gotten to a couple just because it's on a Thursday, which I think it's like 10:30 here, which is hard for me because I usually am seeing people, but they're just so awesome.
Yeah.
One of the things that makes me think about when, I worked in the FQHC as well. And so, the most people that I saw on a day was 15. And I think, yeah, it was a lot, but it's a different type of visit and a different type of work. And for me anyway, it's exciting and invigorating. And I think that you never know what's coming in. So it's always exciting, but you have to be pretty high energy and flexible, because you're rolling with whatever you see versus, now I hate to say, but sometimes I think my work is great, but it's very predictable.
Yeah. Yeah.
So a different flavor.
Definitely have to have the right personality. This has been great. I see that we're still recording and we'll be sending this out.
Thank you. I'm going to stop this.